Hi, everybody. Um, this is my first time doing one of these, and I really wanted to try to address something that is near and dear to my heart, which is the critical illness period for patients with mitochondrial disease, and tell you a little bit about why it's near and dear to my heart, and then I will start going through some slides. Now, I want to be clear about something, which is that I've put quite a bit of science into these slides with the understanding that it's not for everybody. Not everybody wants that information, but there are people that I've met along the way who do want that. And so I'm trying to find a balance for the people in the room, not knowing all of you from in advance. But I will try to read the room and I will try to move through the science if it's not appealing to people, because my goal is really to bring all of you, for whatever your experiences have been, onto a similar page about how the field of mitochondrial medicine is moving towards helping patients, children, adults, when they are critically ill. I hope that makes sense, and I'll do my best to get through this. I am a pediatric neurologist at Lurie Children's, as Kara said, and I also did a fellowship in something called neurocritical care. What that means is that I take care of children at Lurie Children's when they're in the ICU with neurologic illness, whether they're having seizures, they had a stroke, they might be very sick from sepsis and their brain isn't functioning properly. There's a whole wide range of possibilities. Now, I chose to do that before I ever knew I was going to take care of children with mitochondrial disease. That was just something I loved doing when I was a medical student. It's what I chose to do when I was a resident. My interest in mitochondrial disease is separate, and it came from seeing patients with mitochondrial disease and not really understanding why each one was so different. As a scientist, that was very confusing to me, and I wanted to explore that more. So I had these two paths, and they converged when, after some period of time in the ICU, it was apparent that many of the mitochondrial patients were frequently in the ICU. So what I'd like to do today is, if you've had this experience of either you or your child being in the ICU, I'd like to validate that experience. I'd like to show you a little data just from our own center about what we really actually see. If you go to the clinical trials sessions, if you go to a lot of these sessions, you're going to hear a lot about myopathy and fatigue. And I know that in the outpatient setting, that's what's affecting you, but you're not seeing clinical trials on how to improve the hospitalized period of time. We just don't do that because it's very hard to do. And honestly, we don't know a lot about it. So I'd like to validate for the people in the room that have experienced it that this is a real phenomenon. It's not rare for a rare disease. It is common for this rare disease. I'd also like to establish, again, it's different for everybody, but the kinds of things that bring people to the ICU with mitochondrial disease. They may be different for each of you if you've been there. They might be similar. And they are different in some cases for different diseases. This is the part that's going to be the hardest to get through in a timely manner, but I'd like to demystify some of the approaches to treatment in the ICU, meaning from your perspective as a patient. We heard, I think, from the lady sitting in the front row that you get very different care depending on where you go, and emergency letters are important, and I'm going to reemphasize that at the end. However, part of the reason you get differences in care is because people don't really think through the specifics of what they're treating. They just hear mitochondrial disease and kind of go into whatever they know about it. But really, what we're treating is complex medicine, and the doctors are really good at that. If they understand that they can kind of take seriously the mitochondrial disease and yet do what they do best, often they're going to be very successful with some specific guidance that we as educators should be trying to help our colleagues understand better. And lastly, I'm just going to go over the emergency plan, but I heard you guys talking about that before, so I will only just reemphasize that. Okay, hopefully we'll get through all this. And if we do run late, I'm available to chat afterwards, so please come up and talk to me. Okay, so ICU doctors in general, whether they're pediatric or adult doctors, they have a few goals. They really want to move things fast. That's not always a fun experience for families, but it's critical for critical illness. You have to move quickly. If it's your lungs and your blood and your heart, you need blood circulation. So the first thing of resuscitation is ABC, airway, breathing and circulation, okay? So this is like what they're doing. Their first principles are get the body working again. If it's a stroke, time is brain. The longer the stroke goes on, the worse it is for the brain. But in that moment of when they're moving quickly, what they're trying to do is not reverse the process, not solve the problem. They're trying to achieve stability. And those principles actually apply to most people, whether you have mitochondrial disease or not. So in that initial phase, when things are chaotic, most of these ICU docs, and they are trained to do this, they are this is what they practice over and over again. They're just not so concerned about the underlying diagnosis. And if they think about it too much, it might make them less efficient. And that's a fear that they have because that's not what they're trained to do. They see many, many other patients doing many other things. And so that's why often what they're trying to do is address what they can immediately. And they want to do it in ways that they know work, that are tried and true and effective. And the problem is for mitochondrial disease, they're very complex patients, and it's hard to think of complexity when you're doing all of this. And so sometimes, and quite frankly, often, they will run into moments, the ICU docs or the emergency docs, where what they're doing might go counter to what we know about our patients, what we know as the caregivers or as the providers who have seen these patients many times. And that's why the emergency plan is so helpful, because if there are specific things that you know will help your child and your doctor has nicely sort of documented those things, that can be very helpful. It can help in those acute moments to redirect care. Now, not everybody's responsive to it. A lot of these people are, again, trained to sort of tune everything else out. I don't know if people have been watching The Pit. It's the new show that was on HBO. It's actually pretty good. I was kind of surprised at how good it was. But again, like what that show captures, and I think what a lot of the reason why people gravitate towards like emergency room-based shows is because the pace is very intense. And in the moment, that shouldn't affect your child or you. You are just as important as everybody else. But the reality is there's a lot going on there, and the complexity can slow things down. So people are really trained to kind of tune these things out. Okay, that's not a grim view. That's just being honest. And the reason I'm being honest with you is because what's interesting, I think, personally, is that most of these ICU docs and emergency docs actually really like complexity. The reason they got into these fields is because they like the variety, they like the unknown, they like dealing with things that are challenging. The problem is they spend years training and they just see a few of these patients over time. Maybe if they're at a big pediatric center, they'll see more. But even then, each child is different with mitochondrial disease. And so while they love the complexity, that's not really the moment for them to exercise that brain. And they've gotten very good at sort of balancing that act. So that's kind of the context for this talk. And I want you to know that the ICU docs are aware that they aren't as good at this as they should be. That doesn't mean that they are humble about it, but they are aware that there's a gap in care. And so the goal is to partner with them, to help them. We are consultants, the people like me. We help our ICU docs. If we don't show up when they need us, they tune us out. So our job is to show up and be present. Your job as family members and as patients potentially is to provide emergency letters, is to give guidance when you can, and perhaps, if I can offer it, to just give them a minute to settle into whatever they're doing before you start telling them that they're wrong, unless they're going to do something that's going to kill you, which of course we never want that. But I'm being very honest when I say that, like, I think part of what I'm going to show you today is that that's not as frequent as you might think. You might feel scary in the moment, even if you've been through some bad things. Most ICU docs and ER docs are going to do the right thing at first. It's that transition to when they're no longer in the emergency phase where things start to get a little bit more complicated. And that's where we can speak up a lot more. Okay, so at Lurie Children's, when I first started doing this, I was like, I wonder how many of my mito patients have actually been to the ICU. Seems like a reasonable question, right? So this is a pie chart I'm about to show you. Oh, whatever, that's not important. This is a pie chart. The gray on the pie chart, I didn't put numbers in because they're fractions and whatever, but like the gray on the pie chart is the percentage of my patients that have been to the ICU one time or more. The blue are patients that have never been to the hospital, and the orange are patients that have been to the hospital but never the ICU. So what I want to show you there is 50% of my patients. These are patients that I had not even seen them. These are just patients that have mitochondrial disease at Lurie Children's. There's an unbiased search through our system. Half of them have been to the ICU. Now, we're a little bit biased. We're a tertiary referral center. People come to us to go to our ICU. Fine. But my point is, this is obviously much more common than what we've been talking about all week. And I think as I talk to people, people understand this. Lots of patients have not been to the ICU. But I want to show you something even more remarkable. This is a survival curve. We talk about many of you have had the experience of getting a diagnosis of mitochondrial disease and then hearing a really grim prognosis. This blue group, again, is never hospitalized. This is their survival curve 35 years out. These patients are still alive. If they've not been hospitalized, they're alive. They're the ones who are in this room, who are talking to us, if they've been hospitalized, they're still mostly alive. This is 90% survival at 25 years. And the most interesting thing to me is that, yes, look at this. incredibly scary survival curve under the age of 2. A lot of children dying very early on. But if you get out of that sort of 5-year window, then it starts to look a little bit reasonable. And honestly, 30 years out, we have an 80% survival of the patients that have been to the ICU. So this tells me two things. There may be a population here that's very difficult to treat, the infantile severe mitochondrial disease. We don't know that for sure, but it kind of tracks with the way we've always talked about, the severe Lee syndrome patients. And maybe we can get better at doing this, and we really need to target that group. But if we leave them aside for a moment and just talk about the patients who are chronically in the hospital, what can we do to prevent this mortality and make it look more like this mortality? I'm sure there's things we can do. I'm sure that this emergency plan, this acute intervention, this paying attention to a fever a little bit earlier, those are the things that will eventually turn this curve into this curve. And so I'm really focused on this group in sort of retrospective studies to try to understand what those look like, because here's the reality. There we go. This is hospital time, okay? If you've never been in the hospital, you spend no days in the hospital. That makes sense. If you've been in the hospital but never in the ICU, on average, you spend 10 days in the hospital total in your life. That's remarkable to me. 10 total days. But if you've been to an ICU, even once, you've spent 60 or more days in the hospital on average. And as you can see here, the vast majority of those days are in the ICU. So where are mitochondrial patients in the hospital? They're in the ICU. If we're talking about hospital care, we should be talking about ICU care. Yes, you might get admitted to the floor for a couple of days. And again, this is our hospital. We have a huge ICU. We see a lot of patients. But the trend is obvious that no matter who we're talking about, critical care is a huge part of mitochondrial disease. And it needs to be a huge part of our discourse surrounding it. And this is the place where we can make this change. This ICU population is where we can affect this. And I think that gets back to this question of how do you get those ICU docs to start thinking about the complexity after they've stabilized you? Because there is much more to do after that stabilization period. Okay. So who are these mitochondrial disease experts? Many of you have met them. There's obviously geneticists. I'm myself a neurologist, if you can call me an expert. There are other people. Sometimes there's cardiologists, there's renal doctors. Most of us have just come into this because we're fascinated by it and we want to pursue it. But you are going to be very hard pressed, if not, it might not exist. I don't know. I haven't met one yet, so it's hard to know what doesn't exist. You guys are probably familiar with the story of like the black swan. If you see a black swan, then you know it exists. But prior to that, you just don't think it's a possibility. So I've never met a critical care provider who is solely focused on mitochondrial disease as their research, as their career, because they don't see them in the outpatient setting. And like I said, this whole practice of what to do in the ICU setting is not very common for them. So you're not going to meet ICU docs at this conference. That I'm hoping to change, but right now that is not the case. And then I just said there's many mito patients in the ICU. So that seems like a gap to me, an educational gap and one that many people have experienced. And so I like to change the discourse when I talk to my colleagues about, are you really just passing through the ICU like most patients that go to the ICU? You get stabilized, you get sent out to the floor, or is this actually their medical home? And that I just wanted to share. I think we were talking earlier about, I came at the tail end of the last session about people who kind of like know you well and can come and check on you in the hospital. The ICU is often that place for a lot of mito patients. They know all the ICU providers. They know the APNs. They know the nursing staff. They know the respiratory therapists. And yet most of these hospitals weren't designed to have a critical care home. I think that's changing, not just for mito patients, but for lots of other complex patients. And I think that's something where there's an opportunity to have mito patients really benefit from having some longitudinal care. And that sounds frustrating. I understand. You're like, I don't want to be in the ICU. But the reality is that's where the best care is going to come for a lot of our patients. And if the ICU is willing to partner with us to do better, then this is sort of the way I see things going. And I think that's a little bit harder with emergency rooms just because there's so much more shift work and it's so much more variable. But there's a similar concept that can be applied there where the emergency room thinks of what they're doing there as the sort of key portion of the care for the mito patient. That's true for other kinds of patients like with sickle cell disease. The emergency room plan is a huge part of their care. And emergency rooms all around the country have plans for sickle cell patients, like protocols and people that are like specialized in it. So I think that's an opportunity as well. Okay. So I hope I've validated for the people in the room that critical care is a bit of a gap, but that it's a real phenomenon and that it's present for many patients. Whether or not those patients are in the room, you should know as a community, it has affected many of the people. So I'm just going to go through a few things about sort of what brings people to the ICU. I put in more science here than I intended to, again, to try to sort of level set for people. I might go through some of it fast. So if you have questions, please come up to me afterwards, and I'm happy to go into more detail about any of these things. So what are acute presentations in the ICU? Metabolic decompensation. Sounds obvious, but really what we're talking about is that patients who have mitochondria that don't function properly are at risk under certain circumstances of those mitochondria functioning even less properly, and therefore are unable to convert food into energy. That's metabolism. When you decompensate, you just don't do that very well. And that can be catastrophic for the body, and that can result in hospitalization. Part of metabolic decompensation is acidosis, and we're going to talk about that in a moment. But the brain is highly at risk. The heart is highly at risk. The liver is highly at risk. All of these things happen. I'm a neurologist, so I'm a little bit biased. I like talking about the brain, but if I'm not going to show you all the data here, but at least 50% of all of my patients, whether they've been hospitalized or not, have neurologic symptoms. It's by far the most common symptom set that people have. It's also the highest risk of death is associated with severe neurologic compromise. So I'm focused on that. It's a critical illness thing, but I just want to point out that there are plenty of other things. This is just an example of epilepsy. If you have never been hospitalized, this is going back to that hospitalized, not hospitalized concept. If you've never been hospitalized, this green bar, I don't know how well it's showing up, means you don't have epilepsy. So only a small percentage of non-hospitalized patients have epilepsy. If you've been hospitalized but not in the ICU, about half have epilepsy. And this purple bar is something called status epilepticus, which we're going to talk about momentarily. That's a very severe form of epilepsy. And if you've been to the ICU, more than 50% have epilepsy, and like the majority of our patients with status epilepticus come to the ICU. That's just typically true, even if you don't have mitochondrial disease. But my point is this, that in the ICU, these are severe presentations of epilepsy, and they're the thing that sort of brings you in most often. Okay. Another thing that's very common is infections. We all have sort of heard the story that an infection can precipitate a decline in a patient with mitochondrial disease. I was curious about this in our population. So I divided my group in this case into this is now a different color coding. This is a Lee syndrome, or what we call subacute necrotizing encephalomyopathy, SNE. Very, very annoying to say. But yeah, Lee syndrome is the blue group. Sorry, is the orange group, and other PMDs. So again, my population is very enriched for Lee syndrome. That might be part of the reason why the curves look the way they do. But this Lee syndrome population is the most common population across all mitochondrial disease. And so I wanted to divide them out to see. And what this is showing you is that if you have Lee syndrome, you have a 60% chance of being hospitalized for an infection. Name me any other population that has a 60% chance of being not having an infection, of being hospitalized for an infection. Those people are called people with immunodeficiencies. You don't have a 60% chance of being hospitalized for an infection if your immune system works. But we had 0 people talking about immunity this week, right? Because this is another gap in the field. And I think it's another thing where, just to validate people's experiences, this happens a lot. You get infected, you get hospitalized. Other PMDs still, 15% of other PMDs are getting hospitalized with infections. That probably suggests that they also have immune deficiencies. And maybe if you do the math, maybe infection is the primary driver of hospitalization across all these people, which, again, infection is the primary driver of hospitalization for all children, but most children don't get this sick. They don't get this sick. But in our population, large numbers are getting very sick from infections. Embedded in this is something even more complicated, which I'm just going to take 1 minute because some people might have experienced this. We actually looked to see how many of these patients that looked like they had an infection actually had a documented infection, meaning we were able to identify something that caused the infection during the workup in the hospital, a virus, a bacteria, a fungus, something. And what we found, this is shocking to me, what we found, we were very strict about this, was that 20% of all of our patients that had ever been admitted to the ICU had episodes where they never found the bug, but they were on blood pressure support. They got 5 days of IV antibiotics, and they had other signs of what looked like an infection. So they were labeled with an infection, but it was called culture negative. So they were said, you don't have a provable infection, but we think it was there. And so we're going to call this an infection anyway. And this is the highest level of treatment for an infection. 5 days of antibiotics and blood pressure support. After that, you're in a really sick place. But people recover from this. We call it sepsis. So anyway, we call this sepsis-like episodes, which I now realize is SLE. Literally just now realized that. And that's what people also call stroke-like episodes. So I'm going to change that. But we haven't published this data yet, and we're working on trying to figure out exactly what these episodes were like. But 20% of our, this is a feature, not an outlier event. This is something that happens in mitochondrial disease. There's 20 distinct percent, like different patients, 20% of our patients. Yes. It's a great question. The question is that like SIRS, which is an inflammatory response that doesn't necessarily go with an infection? It's similar, but this is a higher level of that. So this would be like if SIRS were like, yeah, right. You actually are on steroids a lot of the time for these. And so like the irony of something like this is that I show this to my critical care docs and they're baffled. They're like, I don't know what to make of that. That's crazy. And then we go and look in our data sets and it's clearly more than the typical presentation in the ICU. I show the infectious data to the infectious diseases docs, and they're like, those kids have they clearly have immunodeficiencies. And then I show it to patients, and they're like, yeah, that's my experience. So what I'm trying to show you is that there's clearly a gap in the care. I totally understand that. I also don't think it's as grim as you may have experienced, because I think we're heading in a direction where these kinds of presentations are increasingly recognized. I'm not the only one doing this. There's a bunch of people who are trying to actually put out for everyone what brings you to the ICU. So this is kind of novel. I just wanted to point it out. I'm going to go through things now that are less novel. Oh, what happened here? Oh, okay. What I skipped over here is that there's other things that bring people to the ICU. I mentioned strokes. I mentioned metabolic decompensation, lactic acidosis. We're going to now go through how to approach some of those things. I'm not going to go through how to approach this because I don't know, but this is something that we will work on. I promise you'll hear more about it. But generally speaking, treating this like it's sepsis is perfectly reasonable and should be done aggressively, because I think until you know it's not sepsis, you have to treat it like sepsis. You should be getting the IV antibiotics and getting support. Okay, so let's talk a little bit about demystifying the approach to mitochondrial disease, because some patients in this room have probably experienced a metabolic decompensation. Some have experienced a stroke. Some have experienced seizures, I'm sure. And so I just want to go through some of these things briefly. And again, I will try my best not to get too nerdy about this. I feel like I've done okay so far. But it's about to get worse. The ICU really, like I said, wants to get stabilized. So they want their patients to live, and they want to do no harm. That's like the first principle of being a doctor. So if it's something exploratory or experimental, they're going to be very hesitant to do it, especially in the critical care setting. And so they want to stabilize, they want to treat, and they want you to recover, and then they want you to leave the ICU. They want you to go somewhere else. And that's just the model of the ICU. It's not a knock on them. That's just how the ICUs work. They are not designed to have people living there for months and months and months. And well, hospitals aren't either. But the point is that like the longer you stay in the ICU, the less they can see other patients who are critically ill. And so they're not designed to accumulate patients. They're designed to stabilize and transfer. And that model probably needs to change a little bit, but that is what it is. And the smaller the ICU, the harder the crunch is. Disease-specific and long-term management recommendations come from elsewhere. So when you are in the ICU, if you haven't seen a specialist from neurology or from GI, it's going to be frustrating because you're not going to know what's going to happen when you leave the ICU, and the ICU has no idea. They have no idea what the plan is going to be when you leave. And yes, they should know. Yes, they should try to figure it out. But in their mind, once they've done these things, they need to get you to the place where these things can happen. So bridging that gap is important, but just to understand where they're coming from, where I go through the next few things, they do care about doing all of these things for the next few things I'm going to talk about. What is lactic acidosis? We hear about it all the time. I'm guessing that some people in the room have it, and I'm guessing that some people in the room have been baffled because they've been told you don't have lactic acidosis, but you have a mitochondrial disease. That doesn't make any sense. This is one of those cartoons of a mitochondria that I keep showing that becomes less and less relevant as we understand more and more about them. But generally speaking, what doctors in the ICU are thinking about when they think about mitochondrial disease is that there's energy failure, which I think a lot of us are thinking. But what they're thinking about is this. The respiratory chain here, yeah, don't worry about all that. Okay, the respiratory chain here is converting oxygen into energy, And while it's doing that, it's pumping hydrogen into this, what's called intermembrane space, this purple area. That's important because the way the energy is generated is that these protons, the hydrogen ions, have to go back through and convert ADP to ATP. That's how you get energy. So oxygen helps all of the protons go this way, and hydrogen going back in is how you get ATP. Now, that's a whole bunch of biochemistry. We don't need to get into why that works or how the magic of all of this happens. But the point is, every ICU doc knows this, and they're thinking about it way more than you'd believe. This is very important to them. They want to deliver oxygen to your body so that mitochondria can do this. They're intubating your child to make sure that they have enough oxygen to do this. They're giving blood pressure support to make enough blood go around your body so that mitochondria in every part of the body can do this. They know that. They're not dumb. Like, they really get this. And they also understand how this biochemistry works very well. I'm going to talk about that in just a moment. Why am I bringing all this up? Because that is how, let's skip through here, looking more closely. Oh, this is the slide I was looking for, actually. Right? So the protons go through into this intermembrane space, you go oxygen, 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 and then the protons come back through and ATP gets converted to ATP, ADP to ATP. Okay. So, so you need oxygen and you need this thing called the TCA cycle. This is like my least favorite biochemistry from when I was a kid, from when I was in medical school. I've forgotten it more times than I've learned it. That's possible. But I now know it pretty well because it's relevant to what I do. But most doctors have learned this and forgotten it. The ICU docs have not. They know this. They know this TCA cycle very well. And I'm going to show you why. The TCA cycle has 2 points here where it's coupled to the electron transport chain. So this electron transport chain, the protons and the oxygen, has to work for the TCA cycle to work, and vice versa. If these things aren't working, if one of them's not working for some reason, or one of them's not working for some reason, then the other is impaired. What you may notice if you're affected by one of these is that the genes that make up complex 1, 2, 3, 4, 5, those are all mitochondrial disease genes. In fact, many of the enzymes in the TCA cycle are mitochondrial disease enzymes. And if you have a variant in one of those enzymes, you may not have proper mitochondrial function. This is why. And so that basic thing that the ICU docs are trying to do, which is deliver oxygen so that this works properly, is inherently impaired, and they know that. So they know that when they do this, it's not going to work fully. But that's okay, because when you stabilize somebody and you give them enough oxygen, a mitochondrial patient, they will produce as much ATP as they normally do, and they'll stabilize eventually. So you have to keep doing those things. The basics of critical care still apply, even though they're a little afraid about it. But something else happens, which is where lactate fits in. If you'll notice over here, glucose has to enter the TCA cycle, which, as I said, has to work with the ETC in order for everything to work. Glucose also goes through another pathway that's not related to the mitochondria. So glucose, this is the glycolysis thing I was talking about, glucose, glycolysis, pyruvate, acetyl-CoA, and it goes into the TCA cycle. But what if you don't have this functioning properly? Then glucose goes to pyruvate, and instead of getting converted to acetyl-CoA, because the mitochondria aren't using it, everything backs up, and the pyruvate gets converted to lactate. And so this is why we talk about lactic acidosis with mitochondrial disease, because the model is that the mitochondria don't work. And so therefore, everything backs up, pyruvate becomes lactate instead of going to the TCA cycle and getting chewed up and processed. Does that make sense? Any questions about this? Okay. This is just this lactate dehydrogenase has a low affinity, so it easily binds and moves over. Yes. And some of it does, by the way, go to alanine. So you can have elevated alanine in mitochondrial disease as well. Yes. Ah, well, that's a great question. I'm showing you a cartoon. This is how everyone with mitochondrial disease lives, basically. So the question is, I think, when this process gets worse. So what I'm showing here is something you can like demonstrate in a dish. Healthy mitochondria, healthy TCA cycle. You can block using a drug. You can block complex 1, and this will happen within minutes. Lactate will start building up. Other things like alanine will start showing up. For patients that have a genetic defect in mitochondrial function, they live at some balance that's abnormal compared to other people. Some of them, some of them live with this, lactate up. That's why lactic acidosis is part of the definition of MELAS. because when it was originally described, all those patients were walking around with lactic acidosis. But now we know there's lots of patients that have what we call MELAS, but they don't walk around with lactic acidosis. But sometimes when they get sick, it spikes. So this is a dynamic process. I can't tell you for everybody how quickly it shows up, but certainly by the time you're sick enough to be in the ICU, your lactate may have spiked. But I'm about to tell you why this is so important, because this is all well and good, but it doesn't really help us treat anything. Yes. It's a great question. I'm going to get to that, I think. But the spoiler alert is that lactate on its own isn't a problem. You can have a super high lactate. It doesn't matter. Is that news to people in the room? The question was, if you have a high lactate and you're walking around with a high lactate, what does that look like? You know, and the answer to that I'm giving you, which is one person's answer, it's going to be different than what you've heard from a lot of people, is that having a high lactate by itself is not a problem. It's not damaging to your body. It shouldn't cause any symptoms. Lactate on its own is not a problem. And that's something that we get into a lot of trouble with medically, because that's not how I was taught. And it's not how the ICU docs are taught. And the reason is because of what you're seeing here. They think of lactate as being a readout of a failure. And so if you bear with me for a sec, I'll come back to that. It's a great question. You just asked this basically. Does elevated lactate equal lactic acidosis? And actually the answer to that is no, because you have to be acidotic to have acidosis, meaning your pH has to be low. Most of us have a pH of 7.4. We typically think of acidosis as being below 7.3. And so that's a huge change, by the way, for your body's pH to go from 7.4 to 7.25 or something. But at that pH, there's no lactic acid in your body. It's just lactate and hydrogen ions. This is like a biochemistry thing, which I understand is going to be hard for people to get if you don't know this stuff. So don't worry about it. What I'm just trying to say is that at that pH of your body, you just don't have lactic acid circulating around. You have lactate circulating around, but it's not an acid in that situation. Lactate has to be bound to hydrogen in order for it to be an acid. That's how it becomes positively charged and becomes an acid. And that only happens at a pH of like 4, which we'd all be dead if we had a pH of 4. So you may be asking, why do people call it lactic acidosis? And the truth is, they're calling it that because your lactate's high and you're acidotic. And they think it's because of what I just showed you before. But the acidosis actually isn't because of that. That's just how the lactate builds up. The acidosis is happening for other reasons. And this is like a really key point that I'm spending a lot of time on, because I think it's important for my friends who I taught yesterday about this, but it's also important for my patients and for the patient population at large, because when people say lactic acidosis, it's scary. I'm going to show you a slide in just a moment for all the things that can cause lactic acidosis. And if you look at those things, you're going to be like, oh my gosh, all those things are really scary, including mitochondrial disease. And my mitochondrial disease patients might have those other things too. The problem is, in all of the situations, the same thing applies. Lactate's building up and the patient is acidotic. But fixing the lactate's not going to fix anything. You have to fix the acidosis. Okay. So yeah, I was just saying all this stuff, but you need this hydrogen ions to become acidotic. If you don't have more hydrogen ions, your pH is going to be normal. You can have a high lactate. It doesn't matter. Just walk around with a high lactate. It doesn't matter. Okay. Right. This is the only thing we're doing. We're not generating hydrogen ions here. We're just generating lactate. So where do those ions come from? Well, I gave you one source of lots of ions in this intermembrane space where we're pumping all this stuff. When the mitochondria fail and they're unable to pump these ions properly and they start leaking hydrogen ions, that's one place where they could come from. There's lots of other places where hydrogen ions come from, but this is a huge amount of them, and they can start to cause acidosis pretty quickly. And like I said, that shift from 7.4 to 7.3 to 7.2 to 7.1, that's major for your body. You can't function like that. You will die if your pH is 6.9, if you're 7.1. If we don't fix it quickly, critically ill, fast, you will not survive it. Oh yeah, I just said many protons. Okay. So maybe if you have decreased proton consumption, maybe you could have increased cytosolic protons, and then maybe they can leak out and you get acidosis. Okay. I'm here to tell you that this central feature of mitochondrial disease, serum lactate, is kind of what we were just talking about. It's taught to everybody. You have to have an elevated lactate to have mito disease. It's supposed to be evidence of mitochondrial dysfunction, which I think I've shown you it can be. Um, but about 25 to 30% of all patients with mitochondrial disease are walking around right now with a normal lactate. That doesn't mean they don't have mitochondrial disease. I've had my own attendings tell me when I was a resident that if their lactate is not elevated, they can't have mitochondrial disease. That's not true. That's just not true. And the point is that it's also non-specific. When somebody's critically ill, your lactate can go up because your mitochondria don't function properly. They can also go up for a whole host of other reasons. There are two types of lactic acidosis. The first type is based on just not getting enough oxygen to your tissues. That raises your pH. And so those are things like heart failure and strokes and things like that. And then there's type B, which is where there's no evidence that your circulation is damaged. You're just generating acidosis for some other reason. There's lots of things in here. I'm not sure if I highlighted some of these that I think are important. I think this is really interesting. So if you look over here, you'll see it's just like some of these diseases that are out there. There's drugs that are out there, and these drugs and toxins that do it are not specifically toxic to mitochondria. You need to use these to help people, but sometimes they end up inducing acidosis. And then, of course, down here it can be associated with an inborn error of metabolism like mitochondrial disease. Yes. Removing them? Oh, yeah, I can. Sure. So over here, I had, take this mic out. I got it. So here, why don't I come on this side? Maybe it's just easier for me to talk like this. What do you guys think? Then I can actually see my slides. So over here we had shock, which is just systemic hypoperfusion, meaning you don't have enough blood flowing through your body. That can happen because your heart's not functioning properly. It can happen because all your blood vessels are dilated too much, and that will cause acidosis. Let me see, did I highlight anything else on this side? Yeah. Severe hypoxemia. So if you don't have enough oxygen getting into your lungs or getting from your lungs to your blood, that will also result in acidosis because your carbon dioxide will build up. And then seizures are another thing where if you're seizing so much that you can't breathe, then eventually you'll become acidotic from that as well. On this side, I picked associated with underlying disease. So I mentioned sepsis earlier. You can have like a thiamine deficiency, an acquired immunodeficiency. There's a lot of diseases that people live a little bit more acidotic for complex reasons, but it can get worse in acute setting. And that is similar to these inborn errors of metabolism where mitochondrial disease would be one. They listed pyruvate dehydrogenase, but all mitochondrial diseases can do this. And then associated with drugs and toxins is what I was mentioning. Tylenol is sort of the classic one. I hope none of you have ever experienced this or seen anyone, but Tylenol poisoning is incredibly common. People take too much Tylenol, their liver fails. But before their liver fails, their pH is like tanked out. It's like 7.1 or 6.9. And that alone will cause them to have a really bad outcome, independent of the liver failure, which sometimes needs to be transplanted. So that's like a terrible toxin. There was a period of time where people didn't like giving acetaminophen or Tylenol to mitochondrial patients, but I think we found that they tolerate it just fine for the most part. Don't want to push the dosing too much, but like, normal Tylenol dosing to help a headache or fever is fine. Okay. So this scheme is really a simplification too, because while people like to talk about type A and type B, if you have sepsis, you're going to have type A and type B. If you have mitochondrial disease and your heart's failing, you're going to have type A and type B. So I think we like to do this from a didactic medical school standpoint, but my point in showing you this is that there's lots of reasons in the ICU, particularly, why your lactate might get elevated. And there's lots of reasons similarly, while when your lactate's elevated, you become acidotic. But we call that lactic acidosis, even though you don't actually have lactic acid circulating in your blood. I know that's confusing. This is seriously one of the hardest concepts in all of mitochondrial medicine, in my opinion. I feel like we talk about it inappropriately. The UMDF could probably be a leader on changing that, but it's embedded at every medical school. It's just a deeply embedded concept, and we're not going to change it overnight. So I just want you guys to know this because I think it's important. And the reason why I think it's important is because the elevated lactate's not toxic. This is the question you asked me earlier. It's not toxic, and it does not mean your patient's getting worse necessarily. You could go for a jog and marathon runners have an elevated lactate at the end of their run. That's not bad for them, unless you think running marathons is bad, which I clearly do. But they are doing a great job running a marathon, and they have lactate, and it's not toxic for them. And that's true for our patients as well. But, and this is the key point, right? This is why it's important. For if you are initially diagnosed with mitochondrial disease and you have an elevated lactate, it's probably a severe form. That means your TCA cycle and your electron transport chain have not been working, and it's a problem. It could be a sign, especially if you don't walk around with an elevated lactate, of worsening disease, and they should be looking for acidosis. If somebody gets a lactate on you and doesn't look at your acid-base balance, they're really missing the point. The point is to look for this, not treat this elevated lactate. So anytime there's an elevated lactate, somebody should be looking for acidosis and trying to figure out why you're acidotic. Lactate is not inherently bad, but it can contribute to problems. So this is like another slide that I I don't know how quickly I should go through all this, but what I want people to understand is that in the ICU, people are going to look at your lactate and say, we have to bring the lactate down. What they mean by that is we have to figure out why the lactate's elevated and address that issue. When patients have mitochondrial disease, sometimes they get a mental block and say, you have a mitochondrial disease, I'm not going to be able to bring down your lactate. That's not true. They should still look for the identifying cause underneath. They should try to reduce lactate with the idea being that you will look better as a patient, but also it's getting lower because you've addressed the cause of the acidosis. And so the actual problem is the acidosis, and you should free these doctors to treat acidosis, encourage them to identify and treat acidosis. People have actually done studies, not on mitochondrial patients, but on other patients, where they try to remove lactate that's built up in a patient with something called continuous renal replacement therapy, which is like basically a fake kidney, like a big machine that acts like a kidney. And they give you a catheter and they clean your blood and they wash out all the lactate. And it does not change the outcomes of those patients. So if we start getting caught up in this idea, and believe me, I've heard of people trying to do this on mito patients as well, not in a studied fashion, just because they're desperate to make the patient better. You hook them up to this stuff, you do this. CRRT is a wonderful and powerful therapy under the right conditions, and it's not contraindicated for mitochondrial patients, but it should not be done just to remove lactate from the blood. It should be done for whatever the other indication would be for using CRRT. So anyway, my point is that these are exceedingly rare situations where somebody would go to CRRT, but this line of thinking of lactate is bad will get you here. And I want you to make sure that you advocate against that if that happens. And then, of course, this goes back to having somebody who they can talk to when the moment is there to say, listen, there's somebody who's happy to discuss this stuff with you. Please contact them on an emergency letter. It doesn't have to be in the middle of the night. Usually it can be like, 9, 10 in the morning. Okay. I spent a lot of time on that, so I'm going to go a little bit faster through some of these other ones. Broadly speaking, what is this metabolic decompensation? I kind of mentioned it to you. Mitochondria make many other metabolites besides lactate, and obviously they make ATP. And so the failure of these processes can affect any organ. You can have mitochondria that aren't producing enough ATP or generating abnormal metabolites in the heart, liver, kidney, as I mentioned. I mentioned the immune system to you guys. And so I think most people in the room have heard of a mitochondrial cocktail before. Many people are on levocarnitine or CoQ10. Thiamine is becoming more common as something people add. Alpha lipoic acid. Vitamin C has now been used in a lot of mitochondrial cocktails, even though it doesn't have a direct mitochondrial benefit that I know of, but it does seem to help the metabolic state in some situations. Certainly people who are low on vitamin D, we try to make sure that they have that as well. These mitochondrial cocktails, what are they actually doing? They're supposed to be supporting the metabolic environment of the mitochondria. So in the outpatient setting, when you're walking around on a daily basis, the theory is that if you take these, some combination of them, some cocktail of them, your mitochondria will function better. We've never proven that. There's no data across all of the research that we've ever done in mitochondrial disease that these cocktails actually help. But I think we're thoughtful about it, and there's some patients for whom it's worth trying. There's some patients for whom it's very expensive and the likelihood of it helping is low, so maybe we should move away from it as just like a thing to do for funsies. But there's times where it does make sense to try things, and certainly I measure all of these things. So if you're ever deficient in any of this, we definitely supplement. But the reason I'm telling you this is because when you have a metabolic decompensation, that would be a time perhaps where some of these might be useful. So in the hospital, when somebody comes in, again, we've never proven any of this works, but the idea is that giving levocarnitine and CoQ10 in the acute setting might be helpful to help somebody recover. And so we do that a lot at our hospital. And so is there any evidence to support thiamine? Well, it turns out that if somebody comes in in the adult population, like an alcoholic comes in with withdrawal symptoms, they supplement with thiamine. And that's because they end up getting like a metabolic encephalopathy, meaning their brains don't function properly. And the reasons for that are not totally clear. You can't really measure a thiamine deficiency in those patients, but it seems like the pathways that are involved in withdrawal end up depleting thiamine in the brain, and there's some evidence that there's mitochondrial dysfunction associated with that. So I've been trying to use thiamine sometimes. And it's not dangerous, right? Like it's used as a rescue protocol. The same thing with vitamin C. It turns out that for sepsis, there's a huge trial that was done on adults where they would give vitamin C in addition to standard therapy, and they saw some benefit from giving vitamin C to those patients. So at our hospital, vitamin C has become part of the standard sepsis protocol. And for some of my sicker patients, I might include it in the acute management. This is the same discussion that we have for mitochondrial cocktails in the outpatient setting. There's no evidence. It might make sense. And I try to do it on a case-by-case basis, but it's very hard to protocolize. But in the setting of metabolic decompensation, we really want to think about these things. There's a couple of other things that people have tried actually in trials. N-acetylcysteine is an antioxidant that's been used a lot. It does seem to boost cysteine in the CSF for patients that have had a brain injury, which is great, but we don't really know what it does for mitochondrial patients. However, I mentioned Tylenol earlier. N-acetylcysteine is also what is given to rescue people who have had Tylenol overdoses. And part of the reason they do that is because it does have a massive antioxidant effect in that setting that might be protective of the liver. And then there's dichloroacetate, which some of you may have heard about as a treatment for pyruvate dehydrogenase deficiency. That has also been tried. There's no clear role right now in acute management. I certainly don't use it right now, but it's becoming more and more clear that there's probably a role for this in the right setting to try to stabilize the pyruvate dehydrogenase complex, and maybe that could be beneficial for other mitochondrial diseases as well. So these are things that we're thinking about trying to use to stabilize metabolism during a metabolic decompensation. We kind of have I will call it a sort of an ICU rescue protocol. First is the obvious things. We treat infections. I already mentioned that. If we don't know that there's an infection, we still treat if somebody's febrile. We also treat the fever itself very aggressively because high fevers can increase metabolic demand. We, if there's no fever, this is complicated. I'm going to skip over that. We also are really focused on nutrition. In the standard of care for most places, any child or adult even who comes in fact, adults even more, will not be put on any kind of fluid that contains calories. They'll just be put on sodium chloride, which is just a standard solution to keep you hydrated. But if you're following what I'm telling you, like these metabolic decompensations are in large part related to not being able to convert your food into energy. And so we want to get early feeds. So if you can't eat for any reason, that's okay. There's ways to put lipids, meaning fats, or proteins into the liquids. Also, giving glucose is not a bad thing. This is another complicated thing, but if you give glucose, you might bump the lactate. This goes back to that graph I was showing you earlier. If you keep giving glucose and pushing that cycle the best you can, you're also going to shunt even more and more of that glucose off to pyruvate to become lactate. So the lactate will go up, but if you were following me, that's not a bad thing. If you're actually getting the benefit you want from the glucose, which is some nutrition, some extra energy for the cells. And a lot of these patients with mitochondrial disease will have hypoglycemia, so their sugar will go low. So they should be getting glucose even if the lactate goes up. But that's like a little bit complicated for this discussion. I think you might be following me here, but the goal is for me to educate the ICU docs on that kind of stuff. The point is that nutrition is important and advocating for that's important. And having dextrose-containing fluids can be important for our patients if they tolerate it. But if not, then getting lipids and proteins into the fluid is important if you can do that. And if not, then as quickly as possible, getting feeds back up and running is really important, making sure people understand that. We also have started to have a very low threshold for transfusion in our patients. This is a little controversial. I'm not going to spend a long time on it, but I want to draw your attention to the fact that in order to get oxygen to the rest of your body, you need hemoglobin. And if your hemoglobin's low, then you can't do that. There's a trend in the rest of the critical care world to use a higher threshold for transfusion than historically was the case. So people have there's shirts in ICUs around the country that say 7 is the new 8. And that's what they mean, is that they're using hemoglobin of 7 now instead of what they were trained on as 8. Pardon? Right. So like it's getting lower and lower and lower. And the reason for that is because for patients who can extract oxygen efficiently from their hemoglobin, they actually don't need as much hemoglobin as we thought. That makes sense. Like it turns out if you test it and you keep testing it, but for mito patients, that may not be true. And so if you're in trouble, adhering to some kind of protocol, when a patient's critically ill and their hemoglobin's low, it may help you to go to a higher threshold. That's going to be a little bit difficult in some places. This is exactly what you're getting at. There's going to be some places that don't care if you say that. They're going to be like, why is a mito patient any different than another one? There's going to be some places that are going to think a little bit more critically in the moment and say, maybe we'll try it because this patient needs it. But there's no right answer to this. And I'm just putting it up there. This is something we've started thinking about a lot. There's specific things. So if you have MELAS, a lot of places in America will give you IV. Almost all the big centers will give you IV arginine if you have an acute stroke for MELAS. We're going to talk about this momentarily a little bit more. I just mentioned, IV Solumedrol. Like a lot of these patients will have some kind of swelling in their brain, like we'll detect it. And so Solumedrol is a steroid. We can give you some Solumedrol to try to reduce that swelling. Again, this is a case-by-case basis. It takes a lot of sort of group think. But we try to think about these things to see if they need them and to get the appropriate studies to decide if they need them. And then obviously the N-acetylcysteine I just mentioned. I've been using it more and more for patients who are really sick, even if their liver is fine. But certainly if their liver is showing signs of injury, I just add it on. And I got a lot of pushback at the hospital. They're like, has this patient had Tylenol overdose? I'm like, no, they have not. They have a mitochondrial disease. They're like, can you tell me why you're using NAC for it? I'm like, because other people think it's a good idea too. My friends and I like it. And it's crazy because it's actually a really cheap drug, but we don't stock it in the hospital as a deliverable. And so it's really hard for them to actually generate the right thing. Yes, it's a great question. Yeah, it's a great question. This is a question about NAC supplementation in the outpatient setting. I don't know the answer to your question. It's a good question. It's something we haven't really investigated very carefully as a field. I have been using, so patients that I put on NAC, I tend to send them home on it for 2 to 3 months, and then I take them off it if they're doing well. And if they're doing well after I take them off it, then I just keep them off it. But I try to transition them off of it in the outpatient. Not every insurance will cover it. In fact, most won't. So it's a bit of a challenge when I send them home. Okay, I have no idea what time it is. I'm losing track of time. Am I out? Okay, all right. So the next few things I was going to talk about were other specific presentations. These are not universal, so I'm going to skip over them because everybody's kind of got different experiences. The other things I talked about were more ubiquitous across mitochondrial diseases. Everyone's heard of metabolic strokes. I want to take 1 second to distinguish something that is like a real pet peeve of mine as an acute care neurologist. And I want to share it with you because I think you guys might experience this, but then I'm going to sort of skip to the end, okay? Metabolic strokes are a very common feature in mitochondrial disease, specifically for MELAS. But that doesn't mean that other mitochondrial patients don't have brain injuries. They clearly do, and there's lots of different kinds. But what I want to show you here is what we're looking at. So imagine you're laying on a bed and your feet are sticking out of this screen and we're looking up through your feet. This here is the brain stem. This is the back of your head. Your eyes and nose would be up here. This is going to be your right side and your left side. Everybody oriented? Okay. Back here, this white stuff you see, that's a stroke on this MRI. Okay. What we do when you have an acute ischemic stroke, meaning like the adult kind of stroke where you like ate too many cheeseburgers and some fat went and blocked one of those arteries, is we look at this white stuff and we correlate it with, I don't know if you can see, but in the same area, there's some black stuff here. Can people see that, or is it not showing up? You correlate those two things and you say, this is a stroke. And for those acute ischemic strokes that happen in adults, they always happen in the territory of a known blood vessel. Why? Because you block that blood vessel. In MELAS, they don't happen in the territory of a known blood vessel. It's a non-vascular distribution. That is a red flag for a stroke, a metabolic stroke. This, to me, is the classic metabolic stroke. Anytime people say metabolic stroke, this is what I think of. The problem is there's another type of thing that happens for a lot of patients. You see this white stuff? It also has a black correlate in here. These are, to you, they may not look different. I don't know. To me, these are fundamentally different. Yes, you have the white stuff with the black correlate. This is what we call diffusion restriction. This is what we call the ADC correlate. But the difference is that this one is very symmetrical on both sides. And yes, it's in a non-vascular distribution, but it doesn't look like an ischemic stroke. It doesn't look like one of those patches of area that just kind of had a stroke. It looks like a brain region on both sides of the brain was affected the same way. Can people follow me on that? Is that making sense? Okay. I cannot tell you how many times my own colleagues at my own hospital call this a metabolic stroke. In the literature, you will find lots of papers that refer to this as a metabolic stroke. And I understand why, because it fits the same imaging characteristics. I blame the radiologists. It fits the same imaging characteristics. So yeah, why not? This is also a Lee syndrome patient who has what looks like diffusion restriction and ADC correlate. It's a metabolic stroke. Why not? The problem is this has a treatment that's kind of like a stroke treatment. This does not. So this imaging difference to me is different. I think if you have MELAS and maybe a few of the other disorders that we have, like I have a picture here for POL-G, we kind of get like these in-between states where it's like, it could be, I don't know if that's really a stroke. You see the darkness here, but not really bright. There's a lot of confusing imaging that's out there. If you have MELAS and you have those kinds of strokes I just showed you, that is one type of mitochondrial emergency. And those stroke-like focal non-vascular lesions, you could have multiple of them. They don't have to be just one like I showed you. I showed you a picture to clearly illustrate it. But the point is when you have those, we have a treatment protocol for them. And those metabolic decompensations that lead to these bilateral diffuse lesions are different, and we don't treat them the same way. We treat them by treating the metabolic decompensation, not by treating the stroke lesion. And so what is that treatment? Let's see, I don't have time to go through all this. Basically, we used to think that you got those strokes because the neurons didn't have enough ATP. And now we think it's because the blood vessels in those areas, the tiny little blood vessels, don't have enough ATP. So we kind of shifted our model. And so now what we do is we try to fix the blood vessels by giving arginine. Arginine helps produce nitric oxide, which causes the blood vessels to dilate. I think I have a picture of that here. There. So if you give arginine, it'll cause vasodilation, and that's supposed to help those strokes. So that's kind of the idea behind giving arginine, is that we've shifted our model from the neurons dying because they're not generating enough ATP to the blood vessels that give blood to those neurons, not dilating enough to give blood to those neurons. Yes. Because it's the small blood vessels. And so it is a vascular distribution locally, but it's not a big vessel that goes and spreads to the rest of the brain. Yeah. Great question. Okay. But I still think of it as vascular disease now, which I didn't used to. And this is like theoretical. This is what we think is happening now. But that's why I get arginine. Okay. I'm going to just point out that Rebecca Ganetsky and Marnie Falk, who many of you may know, did a study on giving arginine to all patients with mitochondrial disease. This is kind of what got me going on that imaging thing. Basically, what they found was that if you got arginine right away, if you had unilateral symptoms, so meaning on one side of your body, which means that only one side of your brain was affected, and if it was a mitochondrial DNA disorder, you were more likely to benefit. And so this to me tells me that like we should really be focusing on MELAS because this basically describes MELAS. Yes. Yeah. You're talking about a MELAS patient who's been on arginine. The question was if they've already been on arginine, will it be beneficial to give it acutely? The answer I think is yes. We don't have really great ways of tracking arginine levels in people in real time because when you send that level, it takes like a week to come back. So the data we have suggests that if somebody's having a metabolic stroke, their brain fluid or CSF level of arginine is on the lower side. Even if they're getting supplemented, we think that's true. I don't know why that's the case, but I suspect that's true. The last thing I want to say about this, then I'm just going to call this, is that the European Mitochondrial Association, or EMA, I think, they do not recommend the use of arginine for strokes. They think there's no evidence to support using it. So while I'm telling you what I'm telling you, that's our consensus in North America. We are fundamentally opposed to their point of view. If you catch us all in a room like this, we'll all admit that we don't actually know one way or the other. But the reason why we're doing it is because we've tried to standardize our protocols so that if there's a benefit, we're not wasting time. And if we can do it safely without causing, again, do no harm, then it's worth the effort. But it's also why I don't want to be treating the Lee syndrome patients and the patients that don't have those lesions. In my hospital, because I get to make this choice, we are only, and it's a big hospital, but luckily it's one person making the call. We don't give arginine to any other mito patients anymore. We did a few years ago because I thought we should. And then as we got more into it and I talked to Rebecca and Marnie and other people, we've standardized our protocol to only confirm MELAS or an imaging pattern that is really consistent with MELAS. And so the imaging is the key element. We get rapid imaging on arrival. Again, I realize you can't do this everywhere. I'm just trying to tell you how we're trying to advance our understanding. Okay, I think we're out of time. I was going to talk a little bit about status epilepticus. If people want to talk about that, they should come and talk to me. It is very common. It is a major problem. It should be treated like status epilepticus. It's not special if it's mito. That's the spoiler alert. And then last is just making a plug for, if I can do this, so many buttons to press, the emergency plan. So yeah, I know you guys have already heard this. I think we don't need to go into why you need an emergency plan, but what I want to point out is that I really think of it as being a patient-specific plan. I think you brought that up really nicely. I think we talked earlier about how caregivers who know you, it makes a difference, and that's really about patient specificity. The more we understand about genetics, the more we understand about gene-specific disorders, the more we understand about our individual patients, we should be putting that into these letters and make them concise and clear, but very directed for emergency care, not like a missive on the uniqueness of this patient. I think, I'm not sure if we showed anything like this before, but this is generally like what we want is contraindicated medications. If there are any for the patient, if we have known abnormal reactions, we want to do anticipatory guidelines for fluids, nutrition, and making sure we treat fevers. And then we want to have patient-specific components like, are there some acute complications that we know about? Are there specific organs that need to be monitored closely? What is the baseline? I think one of the big problems I've found, and a lot of my families tell me this, is that we go to the emergency room, they see my child, they see that they have a mitochondrial disease, and they assume my child is always like this, and that I'm lying to them, that just yesterday they were up and walking and talking and at school. They're like, yeah, this is a delusional parent who doesn't actually have a child like that. So I think it's really important to get level set the baseline. Like, we all have digital phones now. Show them a picture. Say, this is what they were doing yesterday. It's not wrong to do that, okay? I actually now, every visit, I upload a picture into the chart. Like, this is what they looked like on this day. I can upload them into my electronic medical record. So yeah, it's great. But like, so I think actually what patients are now doing is they're sending them to me via my chart, and then they get into the chart that way. So I don't even have to take the picture. It's a little harder for me to do the picture and get it like HIPAA compliant. Can you do videos too? Yeah. This is all in the last couple of years. And it makes a big difference because then in the ICU, for example, when the kid's intubated and it's like, no, but like last week they were in school and they're like, that's not how this works, ma'am. And you're like, no, actually, that is how this works, dude. And like, it becomes contentious and you don't want it to be contentious. I think the ICU people are humble about this because they don't follow patients in the outpatient setting. But the problem is when there's a stress level that's super high and the family just wants their kid back and the ICU docs are like, we're doing everything we can. I think people understand that. I think we can find common ground there. Okay, last thing that I just wanted to point out is that there's a lot of discussion about mitochondrial toxicity from drugs. This is all my way of saying to you, all these things that are up here, they're all on the mitochondrial, UMDF website, whatever. None of them are actually mitochondrial toxins. They're all in dishes. We give high doses, mitochondria crumple up. We say, don't give it. But the reality is almost all those drugs are usable if you use them carefully. The only one is POL-G. If you have POL-G, you should not take valproic acid. That's been shown at least a few times to cause liver failure. The caveat there is that for the patients who got liver failure, POL-G also causes liver failure. It is one of the most common causes of liver failure. So anyway, I just want to be really clear about this, that these are all valuable, but in the moment when you have to treat somebody, something like a volatile anesthetic or an antibiotic, we sometimes need to use those because that's what's there. Acetaminophen is clearly the one that people avoid the most, but I think unless you have really bad liver disease, I'd probably use it. So the point is there's usually an alternative to use. Use the alternative if it's available. But if you can't, for whatever reasons, you can use these and just monitor them very closely. Try not to use doses that are unnecessarily high. I talk to everybody about this all the time. From your perspective, you shouldn't be so afraid of these drugs if people are using them, but you can always ask them if there's an alternative. Could we try that? Okay, how to get an emergency plan. I think we talked about this already. If you guys, I'm just gonna leave it up here. And thank you very much for your time. I'm sorry I went over.